So let's start with the topic mitral stenosis. What happens is during childhood when someone gets infected with group A beta hemolytic streptococci infection, they can develop acute rheumatic fever. Now what happens is 1 to 2 decades after that episode, they can develop rheumatic heart disease, which can include mitral regurgitation, mitral stenosis, aortic regurgitation, or a combination of the above. Now, what can be the causes of mitral stenosis? The most common and the most important one is rheumatic fever. Then, rare ones can be calcification of the mitral valve, it can be congenital, or it can be associated with SLE or rheumatoid arthritis. Now, let's understand the pathophysiology behind the mitral stenosis. For that, first we will have to take a brief look at the normal cardiac cycle. Now, this is our normal cardiac cycle in which first there is systole, then diastole, and as you all know, diastole consists of prodiastole, isovolumetric relaxation, rapid ventricular filling, reduced filling, and then atrial systole. Now let's focus on this diagram. After systole, when the ventricles will start to relax, the pressure inside them will start to decrease, and as soon as the ventricular pressure goes below the atrial pressure, this mitral valve here will open. But in mitral stenosis, this valve is stenosed, which means it is narrowed. So left atrium will have to increase its pressure more than normal to send its blood into the left ventricle. So normally the left atrium is able to push its blood into the left ventricle by increasing the pressure. But let's say one day the person who is having this mitral stenosis suffers from fever or he is doing some exercise due to which there is an increase in the heart rate. Now what will happen is as the heart rate increases, the duration of cardiac cycle has to decrease. Now when the duration of cardiac cycle decreases, there is a decrease in the diastole duration. Now as you all know that the blood 70% of filling of blood into the left ventricle is done by left atrium during the phase of diastole. Now when the duration of diastole decreases, the left atrium has to increase its pressure furthermore in order to maintain the normal cardiac output. Now this increased left atrial pressure will be transmitted further into the pulmonary vasculature. This will cause pulmonary edema and dyspnea. Now, as severity of the stenosis increases with time, the left atrium will have to increase its pressure furthermore to maintain the normal cardiac output. This will be transmitted back into the pulmonary vasculature, which will ultimately cause the development of pulmonary hypertension. This is also called as the theory of second stenosis. Now, this pulmonary hypertension will cause the symptoms of the patient to improve. Why? Because as you can see, the left side of the heart is getting blood from the right side of the heart, and if there is stenosis here, then the left side of the heart will receive less amount of blood, so it will have to pump less. So this pulmonary artery hypertension is causing improvement in the symptoms, but actually it is an indicator of increased severity. Now, since the left atrium has to increase its pressure to many folds, you can easily comprehend that the atrial fibrillation can also occur, and finally when the left atrium is not able to maintain the required cardiac output, the left ventricle failure occurs. These are the two classifications of the mitral stenosis according to surface area of mitral valve. This is the old one. As you can see, mild is more than 1.5 centimeter square, moderate is between 1 to 1.5 centimeter square, and the severe one is less than 1 centimeter square. This is a newer classification in which the stenosis is divided into progressive, severe, and very severe. Progressive is more than 1.5, severe is less than 1.5, and very severe is less than 1. Now, coming to the clinical features. As we have seen above, the patient can have dyspnea on exertion. Why? As I said, when the heart rate of the patient increases, there is decreased duration of the diastole, which will cause pulmonary edema and dyspnea. Later on, the patient can have dyspnea on rest. Now, why this chest pain occurs and syncope occurs? Because with time and with increasing severity, the heart is not able to pump out the blood, so the heart muscles will not get the enough amount of blood. So chest pain can occur, syncope can occur because the brain won't get proper oxygen supply, and the enlarged left atrium can compress on the recurrent laryngeal nerve, causing hoarseness of voice, dysphagia. Now, finally, hemoptysis can also occur because there can be rupture of pulmonary veins or bronchial veins, which is called as pulmonary apoplexy, or it can also be due to winter bronchitis. Now, let's come to the examination findings of mitral stenosis. First, let's see the apex beat. Here you can see the apex beat is tapping. Now, what is tapping apex? Tapping apex is when you can palpate the S1. Palpable S1 is called as tapping apex, because the blood has to go through a stenosed valve, which is the mitral valve. So, same is the reason why the S1 will be loud, because S1 is consisting of M1 and T1. So, when the blood goes through a stenosed mitral valve, it can produce a sound. Now, after apex beat, we come to the pulse. Pulse is usually normal in case of mitral stenosis unless atrial fibrillation occurs, where there will be irregular pulse. JVP, you can have prominent A wave and V wave in JVP due to pulmonary hypertension, but it can also be absent in case of atrial fibrillation. BP will be normal, and there will be wide splitting of the second heart sound. Why? Because the second heart sound consists of A2 and P2, and due to the pulmonary hypertension, the right ventricle will take more time to push the blood, so splitting will occur. Now, this is the characteristic murmur of mitral stenosis, which is low pitched, rough rumbling, mid diastolic murmur, which is heard with the bell of the stethoscope in left atrial position with presystolic accentuation and no radiation. This presystolic accentuation will be absent in case of atrial fibrillation. And since the murmur is low pitched, it is heard with the bell of the stethoscope. Now, coming to investigations, when you will do X-ray, chest X-ray, you will get the straight ring of left heart border, and on echocardiography, you can assess the severity. You can see if there is any calcification or clots. Now, finally, the management of mitral stenosis. We can have medical management or surgical management. Now, in medical management, as we have seen, the increase in heart rate was the problem which can cause dyspnea in the patient. So, we can give beta blockers, and since there were chances of formation of clots, we will give warfarin. In surgical management, we can do percutaneous mitral balloon valvotomy, which basically will improve the stenosis, will cause widening, so that the blood can easily flow from the left atrium to the left ventricle. And in cases such as mitral regurgitation and calcification, we will opt mitral valve replacement. Now, in the end, what can be the complications? As we have seen, atrial fibrillation can occur, clots can form which can embolize to various parts of the body. It can also cause stroke. Pulmonary hypertension was there, pulmonary edema was there. We have seen hemoptysis can occur, dysphagia can occur, and due to compression of recurrent laryngeal nerve, Ortner syndrome will occur. Thank you guys for watching this video.